Surgical operations. Abdominal incisions. Midline incision. This is the midline incision in the middle line of the abdomen. Use. Mostly all abdominal procedures might be performed with this incision. Its location in the midline of the abdomen can be extended from the xiphoid process to just above the umbilicus. It can be continued below the umbilicus by curved incision around the umbilicus. The layers of the midline incision, the abdominal wall, the skin, the fascia, Camper's and Scarpa's fascia, linea alba, transversalis fascia, extraperitoneal fat, and the peritoneum, the innermost layer. The advantage of the midline incision: it gives adequate exposure of most, if not all, of the abdominal viscera. Minimal blood loss. The incision is through the linea alba, which is not highly vascular. Minimal nerve injury, minimal muscle injury can be quickly made, such as in an emergency, can be quickly closed with a mass closure technique. The disadvantage of the midline incision: it needs care just above the umbilicus to avoid injury of the falciform ligament of the liver and its midline scar. The paramedian incision. Its use provides laterality of the midline incision, allows lateral structures like the kidneys, adrenals, and spleen. Its location is about 2 to 5 centimeters to the left or right of the midline. Is over the medial aspect of the rectus muscle. The layers of the abdominal wall during the paramedian incision start by the skin, followed by the fascia, Camper's and Scarpa's fascia, and the anterior rectus sheath. The rectus muscle is freed from the anterior sheath and retracted laterally. The posterior rectus sheath, which in the upper part above the midline, or the transversalis fascia below that level, extraperitoneal fat and peritoneum, and are then incised. The advantages of the paramedian incision: it provides access to lateral structures, no division of the rectus muscle. The incision is in the anterior and posterior rectus sheath is separated by the rectus muscle, which acts as a buttress, giving more secure closure. Can be extended by curvilinear incision towards the xiphoid process if required. Its disadvantages are: it needs long time to make and to close. It needs to be closed in layers. Difficult extension, superiorly limited by the costal margin, and atrophy of the rectus muscle medial to the incision due to stripping the muscles of its lateral blood and nerve supply. Mayo-Robson incision. It is a paramedian incision with curvature towards the xiphoid process. It allows bigger and wider opening. Dissection in the same plane as the paramedian incision. Transverse incisions. The use of the transverse incisions, right or left, colon, duodenum, pancreas, subhepatic space. The location, it is done just above the umbilicus, dividing one or both of the rectus muscles. The layers of incision of the abdomen are the skin, the fascia, the anterior rectus sheath, the rectus muscle, plus minus the internal oblique, depending on the length of the incision. The transversus abdominis, transversalis fascia, extraperitoneal fat, and peritoneum. Its medial aspect is through the layers as in the midline incision. Advantage of the transverse incision: it is less painful than in the midline incision. It gives good access to midline upper gastrointestinal structures. It causes the least amount of damage. It doesn't cause muscle weakness by a denervated segment due to the segmental nerve supply of the recti. The muscular segments can be rejoined, commonly used in children and the obese, as greater abdominal exposure is gained in comparison with the midline incision due to the longer transverse length of the abdomen in children and the obese. The disadvantage of the transverse incision is the limited lateral access, unlike the midline incision, which can then be extended. More wound infections compared to the midline incision may be due to greater difficulty in controlling bleeding and hematoma formation. Subcostal incision. It is used for gallbladder, biliary tract, and spleen surgery, also known as the Kocher subcostal incision, after the person who designed it, with the roof top or chevron modification, access to the esophagus, stomach, kidney, and adrenals and liver is also possible. Another modification is the Mercedes modification. Its location starts in the midline, 2 to 5 centimeters below the xiphoid, extending in parallel with the costal margin, about 2.5 centimeters below it. A rooftop of chevron incision is double Kocher incision. The Mercedes incision involves a vertical incision from the rooftop incision, like a Mercedes sign. Good luck and best wishes.